Hello, AP Psych students. Welcome back for another lecture. We're going to be looking at Unit 12 today. Let's mix those words up. And we're going to be discussing abnormal psychology, abnormal behavior. So Units 12 and 13 really kind of mesh together. We're not going to really differentiate too much between those. Abnormal behavior, Unit 12 is just going to talk about the behaviors specifically and how we diagnose those. And then in Unit 13 we're looking at treatment, so we're going to be looking at all the different perspectives, humanistic, psychodynamic, biomedical, right, etc., on how these psychological disorders are treated. Okay, so let's go ahead and look at our learning targets for today. We're going to be discussing module 65 and 66, talking about the introduction to psychological disorders. So we'll be explaining the differences between normality and abnormality. How do we draw that line, statistically speaking, and then contrasting the medical module called the biopsychosocial approach. Right, this has really helped us in terms of our understanding of psychological disorders and influences, and then describing how and why clinicians classify psychological disorders. So we'll be looking at a little more detail on the DSM-5. All right, and then for Module 66, we'll be looking at anxiety disorders, specifically GAD, general anxiety disorder, panic disorder, phobias, OCD, PTSD, and then at the end of our lecture today, you're going to be examining conditioning, cognition, and biology, and how all these contribute to our understanding of these anxiety disorders. So where is the line between normality and abnormality? So there's 4 basic standards that we're going to look at today. There are over 450 million people dealing with psychological disorders, so it's a very sensitive topic. We need to continue to use appropriate language when discussing these things. That's why I sent you that article to be reading on how do we talk about abnormal behavior, how do we talk about mental illness, how do we talk about psychological disorders, because we don't want to label and we don't want to be prejudiced on these matters. So there are 4 basic standards, however, when looking at abnormal behaviors, right? The first is it's unusual, okay? So if anything's infrequent within a given population, it's unusual, right? Maladaptive, meaning basically it interferes, okay, with the person's ability to function normally in a common situation. This would be abnormal. The behavior is disturbing to others, right? If it abuses social and cultural norms, this would be a standard of abnormality. And then lastly, you have it's distressful. Okay, so if it prevents a person from being able to make rational decisions, then this would be an abnormality. Now, all of these standards are used in the measurement of the statistical abnormality chart here that we see, the bell curve, right? So anything that has a high or a low score on a dimension, right? It could be many different things. It could be intelligence, it could be, just your behavior, that which is disturbing, that which is distressful, that which is maladaptive, right? If it falls too low or too high, then we would say there's a statistical abnormality. And, going back to Unit 2, looking at review of the bell curve, right? Remember, generally speaking, most people tend to fall 1 standard deviation plus or minus below or above the mean, right? Okay, 1 standard deviation plus or minus above or below the mean. Very important for your AP test. Now, here are some perspectives on these disorders, and we'll get more into this when we look at treatment, talking about how all of these perspectives would generally treat psychological disorders. But looking at it from psychoanalytic approach, right, views mental disorders as a product of the inner psychic conflicts, looking at the id, the ego, and the superego. Next, you have the humanistic approach or perspective, and this looks at a person's feelings, self-esteem, self-concept, and the causes of those mental abnormalities, right? So if you have anxiety, it's because you see this gap or this failure between the ideal self that you strive for in your real self, right? And you have the behavioral approach. This stresses the abnormal behaviors learned from reinforcement and punishment, going back to conditioning, right? Classical conditioning, operant conditioning. Next, we have the cognitive approach, irrational dysfunctional thoughts or ways of thinking, right? And this could be, just unrealistic or negative thoughts that we have about ourselves or about those around us, which may lead to depression. Next, we got the biological perspective, or the biomedical or neuroscience perspective, right? And here we're arguing that many psychological disorders are caused more so by hormonal or chemical imbalances when looking at our central nervous system, we're looking at our endocrine system. The biopsychosocial perspective, okay, as with most topics in psychology, there are multiple perspectives that we need to look at. So in this case, we're looking at a biological factor, we're looking at a social cultural factor, we're looking at a psychological cognitive factor, and seeing how all these really interact to produce an understanding of the psychological disorder. So this approach actually gave rise to what's known as the vulnerability model, or the diathesis stress model. In this case, you can see that when talking about the diathesis stress model, it's kind of actually fairly important, and your book didn't address it in great detail, but it's a model that suggests that genetic predispositions combined with environmental stressors either increase or decrease the likelihood of seeing a psychological disorder manifest, right? So this relates to epigenetics because in one environment a gene could be expressed, right? And then in another environment that gene could lie dormant. So for instance, looking at schizophrenia, okay, we know that schizophrenia is very much biologically based. However, the diathesis stress model argues that there are certain factors, right, where these genes that we're born with, the predispositions, can be manifested more so in certain places than others. And so you have these things called risk factors, right? And then you have these other things called protective factors. And you can look on page 674 to kind of see what some of those are. For the most part, risk factors are just environmental stressors, right? So it could be like poor coping skills, it could be extreme stress in a certain time, it could be poverty, right? It could be attachment issues, and then protective factors could be coping skills, like improving your coping skills, cultural resiliency, avoiding stress triggers, right? The diathesis stress model, again, it just suggests that genetic predispositions combined with environmental factors either increase or they decrease the likelihood of developing or manifesting a psychological disorder. Now, this book here, it is known as the DSM-5. It's used to classify psychological disorders. So the Diagnostic and Statistical Manual of Mental Disorders. This is the newest edition. On my bookshelf over there, I have the DSM-4 TR, the text revision. Before that, it was the DSM-4, and then etc. 321. Okay, this version was written and published in 2013, I believe, right? So DSM, the first DSM, was published back in like the 1960s, I think. It only had about 106 psychological disorders. Today, this book has described over 300 psychological disorders. And another important thing to note is that the DSM is not meant to cure. Okay, it's not meant to cure, so it's just meant to describe. It's not even meant to tell us the causes of those disorders. Okay, as that the causes are going to be related to helping the cure, right? Helping cure the disorder. Also, don't go pick up a DSM and start diagnosing yourself with disorders. Okay, I just have to say that because some of you might do it. So please be careful when reading that book. Don't start labeling yourself. When we look here at this question at the bottom, what are some changes to the diagnostic labels in the 5th edition of the DSM? There's a few major changes. The first one, mental retardation, has been relabeled, I guess, as intellectual disability. So mental retardation was actually used to take away some of the stigma of the labels from the past. However, now that label, mental retardation, is kind of a stigma, right? So now you have a new label for it, intellectual disability. Okay, next we have autism and Asperger's. These two, this is kind of the one that's most noticeable. And these originally were different and separate disorders, right? Now they're actually unified, and it's just called spectrum disorder. So both of them fall under the spectrum, is what you'll hear behavioral psychologists discussing. And then you have new disorders that have been added, right? A few that I wrote down here. I have hoarding, hypersexual disorder, binge eating disorder, right? So some of these have been added. And interestingly, when I was doing a little bit of research, I found that there's actually some other disorders that have been added or that are being debated right now. And so an important thing to remember is when they are making revisions to the DSM-5, there's very serious debate when adding these things or omitting things, like the one that I just discussed. They omitted something, right? So a lot of research and a lot of thought goes into this. It's not they don't just make this book on a whim. Okay, so this debate, though, that's I think is kind of interesting, because the part of the world that we live in is gaming, right? So internet gaming disorder is actually being listed in the DSM-5 as a condition for further review. And so, I mean, you see people, especially in China and here in Hong Kong, they're extremely addicted to video games and screen time, right? And so it's really wreaking havoc on their lives and their ability to function normally in society. You know, I mean, if you're gaming 8 to 10 hours a day, I think that's a problem, right? And is it abnormal? Is it harmful? Probably, yeah, probably is. So we'll see what happens in the next DSM-5, DSM-6. Okay, now looking at some of the criticisms, the first one here could say that it casts too wide a net and brings almost any kind of behavior within the compass of psychiatry. So we gotta be careful. There's so many. There's over 300 plus disorders, right? Psychological disorders defined in this book. And so it seems like, man, are we trying to find a disorder to explain every behavior? We're gonna be careful with casting too wide a net. Next, over-labeling. This kind of goes with stigmatization, but over-labeling what might be a common behavior. For instance, you know, I mean, if somebody's expressing grief after losing a loved one, right? Well, that's normal. It's normal if they're depressed and socially withdrawn for a period of time, right? I mean, so another example here is the DMDD, right? Disruptive mood dysregulation disorder. So if a child has a temper tantrum, you know, do we label this kid as a child struggling with DMDD and then medicate him, right? You know, what effects is this going to have on him in his childhood and later adulthood development, right? Giving a child strong medication when he's just angry, right? He's just throwing a tantrum because he didn't get his way. So we got to be careful. And then the last one here is stigmatization of labels. So stigmatization, right? Labels, are they needed? Yes, they are. They are needed, actually. We need them to describe disorders and to understand the behavior, what to look for, and to find them help, right? So DSM-5 has done a lot of good, but it's also done some bad, it's done some harmful things as well. And you have this prejudice factor that's kind of come into play. So further explaining this point on stigmatization, David Rosenhan did some really important research in which he looked at on being sane in insane places. So he basically did this pseudo-patient experiment where he and his associates went to 12 different psychiatric hospitals and were admitted. You know, they were mentally healthy people, right? They're pseudo-patients, and they were admitted into these hospitals by all the doctors and diagnosed with schizophrenia as they claimed to be hearing voices. And they mentioned kind of the same story, and they didn't really show any other psychiatric problems. And after the interview, they acted completely normal. They stopped. They reported that they weren't hearing the voices anymore. They were fine. But after they were labeled, what they saw was that none of the doctors found the trick or the deceiving factor in any of these pseudo patients. But two, after being labeled schizophrenic, everything they did in terms of their behavior was labeled, right, and seen as a manifestation of the illness. And whenever they tried to deny the illness, right, it was considered as further manifestation of the illness. And only when they agreed with the diagnosis did they actually see progress in their treatment and in being discharged. And so at what point, so that relates to what I'm saying here, at what point does a label distort our interpretations, right? Once we label someone as schizophrenic or ADHD or autistic, right? We just start looking at all the behaviors that they have and make these distorted interpretations of everything that they're doing. When in reality, a lot of what they're doing is actually very normal, and we do ourselves. So we become very prejudiced. Second major thing here is once diagnosed, will that label carry over into the rest of their lives? And so labeling somebody mentally ill can leave someone with a permanent disadvantage, right, in society. Taking medications for anxiety or ADHD, it can have some effects on getting a job, getting an interview. If you've said that you were previously released from a psychiatric hospital, it's going to affect your future, and it's unfortunate, but this is the reality of stigmatization and labels. All right, I want you to go ahead, think critically here for a moment, and record your answers to these questions in the comment section. What are the benefits to diagnosing and labeling certain sets of behaviors? There are benefits. The DSM-5 is a good thing. And how can labeling and diagnosing be detrimental to individuals in society as a whole? So, all right, go ahead and write your response. So when looking at these disorders on a globe scale, okay, we see that illnesses are found throughout the world. So across the globe, the WHO did this study based on 90-minute interviews with thousands of different people in 20 different countries from different socioeconomic statuses, from different genders, different ages. It was a pretty good distribution of the world population. And this is what they found, right? The U.S. National Institute estimated that just under 1 in 5 adult Americans currently have some type of mental health or behavioral or emotional disorder. So from this research by the WHO, you see that the United States is clearly at the top of the list. And there's several reasons. There's a lot of reasons why this could be. I think one of the major ones is just the fact that in the United States, they have some of the best access to mental health research and mental health treatment and mental health programs versus some of these other countries. But you do see a lot of other developed countries on here, specifically some European countries that are developed. And in those countries, there's lower violence rates, right? There's gun laws, right? There's no gun laws in the U.S. And so I think that not that there's no gun laws in the U.S., but there are a lot less restricted gun laws in the U.S. So that violence probably has another factor to do with the statistics here. Okay, and when we look at which disorders are most prevalent in the United States, we see that these are the top ones right here. Okay, so you've got depressive disorders, phobias, social anxiety, ADHD, PTSD, GAD, schizophrenia, obsessive compulsive disorder. And when looking at which ones are most prevalent. The first category would be anxiety disorders. So it makes up about 29% actually of these disorders if you add them all up, and they're kind of divided here into more specifics. But the entire category of anxiety disorders, looking at like agoraphobia, phobias, social anxiety, general anxiety, OCD, right? Those are all going to add up to be the highest disorder category seen in the United States and worldwide. And then next you have depressive disorders, right? So what are some risk factors for depressive disorders? Probably worldwide, poverty, right? Socioeconomic status. Like poverty is probably one of the most major incidences of serious psychological disorders, where you see about 2.5 times higher risk when you fall below the poverty line. So that's a major factor. Also in some of these other nations, they don't have, like in Nigeria, they don't have a lot of access to mental health care. So that could be another risk factor. And then, other things include traumatic events that you've gone through in your life, right? It could be academic failure, it could be birth complications, it could be genetic, right? It could be low birth weight, neurochemical, it could be trauma-induced, high extended stress for a long period of time, personal loss. Could be a lot of different factors. Now, this is the Taylor Manifest Anxiety Scale. I'm actually going to post this for you guys on PSL to fill out and kind of go and see where you land on the stress meter. But basically the way you read this is high level of stress is anything 16 and above, right? Anything below that, 6 to 15, is generally seen as pretty normal to intermediate stress. So, and we all deal with stress, right? I deal with stress, you deal with stress. We have to learn ways to cope with that and to manage it, right? But in the comment section, I want you to go ahead and respond to these questions. Describe a time when you have been anxious, what caused this, and then how did you deal with it successfully, right? In order to overcome our stress, we need to reflect back to times where we managed it successfully. Otherwise, it's going to continue to run our lives. Okay, looking at the first disorder here, GAD, general anxiety disorder, defined as a prolonged tense state with autonomic nervous system arousal that causes out of control agitation, right? For generally speaking, 6 months or more is when this would be diagnosed. So we talked about the gas theory, right? In the sense that if we are stressed for too long of a period, then eventually it leads to fatigue, right? Our body shuts down and we become ill. So same thing here, right? If we have high intense anxiety for long periods of time, it's going to lead to some kind of chronic fatigue. And generally speaking, we do see this disorder more so in women than in men. 2 out of 3 people diagnosed with it are women, so it affects twice as many women than it does men. Also, many people with GAD also suffer from major depression and have to use some type of treatment for this, such as an antidepressant. And we'll talk about these antidepressants more so later in the next unit, looking at like Prozac and Zoloft. And these are used to block reuptake, serotonin reuptake. Okay, next you have panic disorder, and this is marked by sudden severe feelings of extreme anxiety or fear, generally of a terrible event, right? They think that a terrible event's going to occur. So this is Charlie Belgian, and he's a golfer in the PGA. He experienced a panic attack when he was actually playing a tournament. He had a pounding heart, rapid breathing, started getting tremors, became very nauseous, became dizzy. He fell over and couldn't finish the tournament, actually. Anyways, these panic attacks happen, and what they can lead to is possibly phobias. So there's links between phobias and panic disorder, because when something like that happens in public, right, you may develop a fear or avoidance of public situations because you associate that public situation with the fear and the anxiety that you're experiencing, and then you never want to be in public, right? So like agoraphobia, for instance, the fear or avoidance of public situations. So kind of a continuation from that previous slide. Agoraphobia, you're looking at irrational fears of public places, right? And this, like this golfer, for instance, that we were mentioning there, clearly falls within this description of what a phobia is: persistent and irrational fears of an object or situation that disrupts the behavior. So a person experiences sudden episodes of intense dread. Okay, here's a bar graph of just some common phobias that we see in people and in their lives, and psychologists have labeled over 700 different fears and phobias, and they say there could be like 1,000 more, right? So generally speaking, phobias are some of the most successfully treated disorders around, yet a lot of people still don't seek treatment for them. So right now, what's everybody afraid of? Germs. Germs, man. With the coronavirus, people are so afraid of germs that they won't even go outside. They won't shake anybody's hand. They won't talk to anybody. I mean, it's a concern. We do want to be sensitive to the issue, but we also don't want to just live in severe fear of germs. Like, God's bigger than germs, man. I was reading Psalm 91 today, and just check it out. It's a good passage. We're so focused on self-preservation that we're not looking at anyone else around us. And I'm not trying to rant here, but I even think of like Jesus Christ and the lepers, right? I mean, nobody wanted to be around those people, but he embraced them, and he went to them. And so as Christians, we need to be very careful about our fear of germs right now, developing this phobia of germs. Don't be so weird about germs. Don't be so afraid. Don't be so focused on self-preservation. Okay, that's my rant. Moving on. Okay, what are you afraid of? Think of some fears that you have. What differentiates a fear from a phobia? I'll give you guys some feedback on this at the end of the presentation. When you look at your answers, why might people be reluctant to get treatment from their everyday fears, right? So when looking at like certain phobias, why do we see that some people don't actually seek treatment, even though it's one of the most commonly and easily treated anxiety disorders out there? Okay, record your thoughts. Now, when looking at OCD, obsessive compulsive disorder, we see here that it is the persistent unwanted obsessions, we're talking about thoughts here, right, that cause someone to feel the need to act or engage in a particular action, right, compulsively. So there are two specific factors that lead to OCD. The obsessive thoughts, that's the first factor, right, and then the second is the compulsive, obsessive, ritualistic behaviors. Okay, so we have those obsessive thoughts, those repetitive worries. That is going to in turn increase our anxiety, right? And then the compulsive behaviors is going to decrease the anxiety. So if you're thinking about that like on a cycle scale, right, you got 4 steps to explaining OCD. The first is obsessive thoughts. The second is going to be increased anxiety, right? The third is going to be the compulsive behavior, and then the fourth is going to be temporary relief of that anxiety. Okay, so that's kind of the cycle of OCD, and you can see it take place in so many different ways, right? It could be obsessive hand washing, it could be counting everything in a very unimportant and unhealthy fashion. It could be checking things over and over and over and over again, like, did I lock the door? I don't know, I need to go check again, right? Like, well, I just need to go check again. I'm just going to go check one more time. I'm just going to go check one more time. Okay, that's probably enough. But, right, if we're checking 10 times within 10 minutes if we lock the door, that's probably an issue. All these would be related to compulsive behaviors. So, Justin Timberlake actually is somebody I really respect, and he's somebody who has struggled through this, but he's had a lot of support from his family, and they've really helped him. Now, if we look at this brain here, this is a PET scan looking at it from a biological perspective, right? We see here on the left, you see a much higher concentration of brain activity and neural impulse firing versus this brain here on the right with no OCD. And there's actually some research that is tending to say that there may actually be a neurochemical imbalance that causes this OCD and this overproduction of serotonin. But we don't know that for sure yet. So also when looking at other factors of what happens with OCD is because you have such severe and high anxiety, people become very depressed as well, and sometimes develop suicidal thoughts. Because think about it, like if you're constantly anxious, like all the time, like about everything around you, and having to consistently live through relieving that stressor, man, I mean, it'd be really hard to deal with that. So and also just to keep in mind, maybe be a little more sensitive when you say that, right? When somebody does something and you're just like, oh, you're so OCD, we use that really liberally. You be careful. Okay, last disorder we're going to discuss today is PTSD, post-traumatic stress disorder. So following a person's involvement in or an observation of an extremely stressful event, okay, this could be related to many different things, right? It could be military combat, it could be kidnapping, it could be rape, it could be sexual abuse, it could be a violent crime, it could be a robbery, it could be a death of a loved one, a natural disaster, so many things. We generally fall into what's known as acute stress disorder, and this is pretty normal, right? But after we go through the acute stress disorder for over 4 or more weeks, we become diagnosed and constituted as someone with PTSD, right? And some of the symptoms in this will be continuation for months and maybe years of haunting memories, of flashbacks, possibly, nightmares, waking up with severe nightmares, and uncontrollable crying, social withdrawal, jumpy anxiety, sleep issues, right? Because of nightmares. Only about 10% of women have this. About 20% of men react to traumatic situations through PTSD. I'm not saying 20% of all men and 10% of all women, but 10% of women who go through traumatic situations, 20% of men who go through traumatic situations develop PTSD. So it's essentially double, right? But a lot of military go through this, and during the Vietnam War they called it shell shock, which just kind of became a common term used to describe this for a lot of men who were diagnosed in U.S. hospitals. So there's some strong evidence too that shows some genetic predispositions here as well to the fact that when you go through these traumatic events, there may be some epigenetics related to it and where that gene is expressed because of the environment. All right, that's it for today. I want you to go ahead and look at this learning target. I want you to apply your understanding based on the things we've discussed. So looking at it from a behavioral perspective, what is reinforcement? How does it explain anxiety, OCD, PTSD? Looking at the cognitive perspective, how does cognition impact anxiety? And then the biological perspective, how do genes impact anxiety, OCD, and PTSD? Again, after you answer and respond to this, I will post some feedback for you and the answers after you finish the Ed puzzle. All right? Okay, everybody, take care. I'll see you guys later.